I quoted Tony Nevin's observation that, quote, commitment to a faith, either religious or behavioral, need not exclude ideas from outside that faith, unquote. I think no one in contemporary behavior analysis epitomizes this observation better than Ben Williams, who's a professor of psychology since 1973 at the University of California in San Diego. Over a remarkably productive career that started with a BA degree in psychology in 1966 from the University of Kentucky, followed by a PhD from Harvard in 1970, Ben has proffered brilliant observations in more than 100 publications on a host of topics in reinforcement theory, quantitative analysis of behavior, and stimulus control. And more recently, he's been working in the area of intelligence. In addition, he's a highly sought-after reviewer and editor of professional journals that publish articles on all these topics. Ben's experimental work is characterized by creative designs that beautifully tease apart complex phenomena, and his theoretical integration of that work is characterized by a remarkable grasp of broad issues in learning theory. He begins from a behavior analytic perspective, but then connects his analysis to a range of other ideas, from traditional Hull-Spence learning theory to modern associationist theory to animal cognition. The result is a unique perspective that's a model of integrated conceptualization. Following a diagnosis of a normally terminal malignant brain tumor in March of 1995, Ben turned his considerable analytic and research acumen to his own survival. Often running counter to conventional medical wisdom, he researched and then created his own treatment regimen, doggedly pursued it against all odds of success, and sometimes against the judgment of the medical community. Fortunately for both himself and our discipline, his experiment worked. He since has functioned as a consultant for other people in the same situation that he found himself in 1995. His experiences culminated in a 2002 book, which is on the screen before you. And today he's going to talk about some of those experiences in relation to behavior analysis. Okay.
Thank you, Andy, for a very gracious introduction. I guess the motivation for this talk is actually a conversation with Richard Fox, who encouraged me to do it. I hadn't really thought about doing it until he said, why don't you, why not have this decision get made? But in reflecting on my own experience, one of the things that became apparent to me, may or may not be apparent to you by the time I finish, was the way I thought about the situation I faced, was the way I thought about behavioral phenomena as well, and many of the concepts of behavior analysis actually do have a role in medicine. And if you look at how medical research is done, it's surprisingly like psychology. And many of the issues that you have in psychology about null hypothesis testing and how you design experiments, I mean, in both cases what you have is a lot of noisy phenomena, and you have to figure out what the order is in the noise. So in that sense, it really was not as foreign a territory as it at first seemed like it was going to be. Let me first tell you a little bit about the disease I had, I hope to say, and then a little bit of my case history, and try to take examples from it to illustrate some general points that I want to make later on. My diagnosis was something called a glioblastoma multiforme. Sounds ominous, just from the name. And in fact, it's probably one of the two worst types of cancer to get. The principal competitor is pancreatic cancer. You probably know it's pretty much universally fatal. And the general consensus at the time of my diagnosis, and largely still the case today, is that anybody who has this diagnosis of a glioblastoma is almost certain fact, a paper in the Proceedings of the National Academy of Sciences just a year or so ago with the title "The Terminator." It's referring to this type of brain tumor. In actual fact, it's very hard to get a reliable estimate of how many survivors there are. There clearly are some survivors. And part of the reason is that the government doesn't keep very good statistics. Other countries keep better statistics. And we're beginning to here. For a long time, the problem seemed to be that each medical center seemed to not want to share information with anybody else. And so, in part, I guess, they can claim anything they want and not be held accountable. But anyway, from other countries, the 5-year survival rate is somewhere between 1% and 2%, and that is sometimes questioned because of mistakes in diagnosis. Sometimes things that are lower grade tumors are diagnosed as a glioblastoma and will do better because it was expected because of a mistake. And in fact, there's also a question of how you partition the whole population. So if you exclude people who are less than 35 years of age, and age matters a lot with these diseases, the survival rate goes down about 0.5%. So the base rate's not a favorable thing to confront when you've just been diagnosed. When I was diagnosed, I remember the experience very well because I was friends of mine insisted that they take me to the emergency room. We just had a poker game the night before, and I had all the money, so they thought I was sick. But I had a variety of symptoms, one of which was in all these chips that I had won that night, the ones that I had on the right were all neatly stacked, and the ones I had on the left were one big disorganized pile, as if I didn't know they were there. And then there were various other things. Anyway, I went to the emergency room with their assistants, and here's what I saw when I got out of the MRI machine that they immediately put me in. If you've never looked at MRI slides, let me tell you a little bit about what they do. So they take a series of slices. Different centers will have different thickness of slices. In this particular case, there are about 15 slices in each dimension. So they run a series from top to bottom, side to side, and front to back. This is from the top to bottom one. This is right in the middle of the series of slices. And the other thing you need to know is that when they give you, before you go into the machine, they give you a shot of something called gadolinium, which is a compound that supposedly does not cross the normal blood-brain barrier, but does cross the disrupted blood-brain barrier of tumors. The rationale is that tumors no longer have an intact blood-brain barrier, so this compound will make it into the tumor, but not in the normal brain. And so when you see an illuminated white area there, that actually represents the presence of that compound, and therefore supposedly the presence of the tumor. But so this degree of tumor infestation was only about half of the 13 or 15 slices in that dimension, and also on about half. This is a front to back slice, and about half of those as well. The dark areas there are fluid representing ventricles, obviously. This was not a welcome surprise when I got out of the MRI machine. The resident neurologist on call actually couldn't bring himself to tell me what he had just seen, so he invites me over to look at the monitor, which was where they had the film already, from the machine already there, and he said, "Well, look, here's what you have." And needless to say, it was a shock. In fact, it was quite unusual for them to have seen the size of the tumor that I had, which was described as the size of a large orange. actually, by my estimation of the dimensions, it was 170 cc's. If you know about brain volume, the typical male brain is about 1,500 cc's. So it represented a significant portion of my brain. And that portion of my brain is actually no longer intact as a result. So don't be too hard on me when I stumble along here, because you're talking about a neurologically deficient person. When I saw my neuro-oncologist after the diagnosis and after the surgery, I can show you, I forgot to show you the next slide. So here's what happens after surgery, right? So it doesn't seem like things improve very much. The big white mass is tumor. My neurosurgeon later told me he'd been very conservative in his approach, because parts of the tumor were actually getting down to the internal capsule, which you may know is where the motor fibers run out of your brain. So he didn't want to leave you paralyzed. And at the time I was a little pissed off, but in retrospect, it's the best thing he possibly could have done for me. But in any event, so here's after surgery for the other corresponding slide. So my neurosurgeon refers me to a neuro-oncologist, and met with him, and he says, okay, here's what you have. The median survival time for someone just diagnosed is about a year. You're in pretty good shape, and that seems to matter a little bit. And so you have a good chance of making it to 18 months. There's absolutely no discussion of surviving any significant amount of time. So the question is, why am I here? I have a lot of negative prognostic characteristics. The size of the residual tumor after surgery is a very powerful indicator of how things are going to go, because if you have a lot of residual tumor, things usually does not respond to treatment simply because it's so large. And I also wasn't one of those people at less than 35 years of age who tend to do better. It didn't look hopeful, I guess would be the best way to describe it. One of the things that quickly became clear is that I wasn't going to get any real sense of what I was dealing with unless I did my own research. I mean, the doctors, you come in, you have a 30-minute session, and they tell you what they recommend, and that's about it. So I began doing research, and actually, my own personal background was pretty important here. If you know me at all, you know that I'm very much an iconoclast, and I don't have much respect for authority. And so the result was I didn't take any of what they had to say seriously, and I was going to find out myself what really was the situation. What I found out from my initial research was the situation was every bit as bad as I'd been told. So every journal article begins with a description of the dire prognosis of anyone diagnosed with this type of brain tumor. But I also began discovering a number of things. One was that they reported their data in such a way you really couldn't figure out what went on. So they very often just report median survival time, some statistic or other, if they had the type of trial that yielded statistics. But it became clear that some people did benefit from some treatments. Right? Not that they were cured by them, but the thing that was apparent to me, because I had so much residual tumor, was that the only thing that I had any likelihood of having success was chemotherapy. And chemotherapy notoriously had not been successful for a very large percentage of people. But it did seem to help about 20% of patients, so that they were the ones who lived 2 years rather than 9 to 12 months. But it was really about 15 or 20% of people who got this benefit, and it wasn't a huge benefit at that. But if you look for anything you can in that situation. And so for me, the question was, okay, how can I make chemotherapy work? And that turns out to be an interesting question still. It's not just a question of does chemotherapy work or not. There are things you can do to make it work better than it does. And one of the things that people now know is that tumor cells have all sorts of genetic regulators to combat whatever injuries that they have from the treatment. So if the cell's injured from radiation or is injured from chemotherapy, rather than just dying like it's supposed to, the cells can often have a counteracting genetic upregulation that will prevent that from happening. The cells also adapt by learning to, and it's almost like a learning effect, learning to extrude chemotherapy from a cell before it has a chance to kill it. So the cells only are killed by chemotherapy when they're dividing. So if you happen to not have a dividing cell, chemotherapy agent goes in, sits inside the nucleus of the cell, but then if the cell kicks it back out, and obviously it won't be there when the cell is dividing and therefore has no effect. So there are actually ways of thinking about that. And one of the things I discovered is that there's been a long history of research on this, discouraging history in the way people had concluded and interpreted results. But one of the things that popped out of it was there is a class of common drugs that people use for blood pressure called calcium channel blockers. And part of this extrusion mechanism involves calcium channels. And so there have been a number of studies where calcium channel blockers actually seem, certainly in the animal models, calcium channel blockers made chemotherapy much, much more effective. So there were human studies of this, but most of them yielded a negative result. But in fact, that was the first thing I learned, is that what they considered a negative result wasn't necessarily negative. That their medical world thinks of itself as, as doing science like the rest of the world. Namely, they're looking for a very conservative criterion before they conclude something works. And so if you look at these studies, some of them look like there probably is something there. And given that the drug involved, something that, like I say, millions of people have used, has no toxicity if you don't overdose on it, it made no sense not to use it. So I went to my neuro-oncologist and said I would like to start taking these calcium channel blockers along with chemotherapy that he was prescribing for me. And he refused to do it. A benign drug. I didn't think there would be any real problem with it. So there was just no evidence that it works. Well, by his criteria, the evidence was weak, certainly. Fortunately, I'm on very good terms with my internist, and he said, I'll do it. So I got my prescription after all. Well, I had no idea whether it's going to help much, but the one theme that's going to run through all of this is you have to think of things in terms of probabilistic effects. There's a probability that this would benefit. I thought a real probability that this would provide benefit, and it made no sense not to try. So I added that to the treatment program. The other thing that happened during my research was I discovered that there are a lot of existing drugs that have direct action on cancer, in particular this type of brain cancer. That these drugs were developed for something completely different, and people discovered after the fact that they had this effect on cancer cells as well. And the reason for this is that people began to have a sense of, or a deeper understanding of exactly what is happening when cancer cells become malignant and start dividing very, very rapidly. And there are a series of these. Now what you see in the news are the actual engineered drugs that target these various kinds of processes that have gone awry, and there is some real progress in the last several years. But 9 years ago, these things were in very early stages of development. But because they had an idea of what the actual critical processes were, they began looking at existing drugs and say, do any of these do any of these things? And it turns out many of them do. And the one that I hit upon very quickly in doing a lot of research, and let me say my story would not be possible were it not for the internet. That you will find that you can get an enormous amount of information very quickly if you go on to PubMed or Medline. Well, Medline no longer exists and converted into PubMed, which is available to anybody, and you can just get tons and tons of information. And so one of the things that pops out of this was a commonly used drug for breast cancer, that you've all heard of, I assume, called tamoxifen. And tamoxifen is widely used because it blocks the estrogen receptor and prevents the growth stimulation effects of estrogen on breast cancer cells. Well, it doesn't do that for brain cancer, but it turns out that if you take really high doses of tamoxifen, and I ended up taking very high doses, about 10 times what a breast cancer patient would take, it blocks a process called protein kinase C, which is very much involved in proliferation of brain cancer. Interestingly, it's an important component of the learning process. So when now people look at the cellular basis of learning, protein kinase C plays a critical role in it. But in any event, it turns out that there was this evidence from one small study done at USC where there were about 40 or 50 patients, and of those, about 40% of them had their tumor stop growing for not a long period of time, but a significant amount of time, and some of those actually had their tumor shrink. But it was all, this trial was based on people looking at the process and trying to figure out, what do we have that will address this process. So I went to my neuro-oncologist again and said, okay, here tamoxifen seems to do something. I'd like to take it along with the chemotherapy. Of course, I've already had this problem with verapamil, which was the calcium channel blocker. And what I found was he was totally uncooperative. He said, well, the evidence for this is really not very good, and it might hurt you. We don't know what the effect of you taking this while you're doing chemotherapy. Now, this is someone who, the meeting I'd had with him before told me that I was going to be dead in 12 to 18 months, and he's worried about some imagined danger of this drug that millions of people are taking. But that clearly wasn't the reason. It just was not, he just was not going to cooperate because it was too far off the beaten path. No one at that point had ever combined tamoxifen with chemotherapy. And he wasn't about to be involved in being the first one to do it. So we had a disagreement that got rather heated. And I basically told him, well, I'd get the drug one way or the other. And he said, well, if you're going to do that, then I'm going to quit. And I won't be your neuro-oncologist anymore. I said, fine. It wouldn't do me any good anyway. Well, little did I know at that point that he was the only neuro-oncologist in the San Diego area. So I was faced with a rather difficult situation. But I have a lot of medical friends, and so I went around to a lot of them and said, well, do you know any just normal oncologists who are not specialists in neuro-oncology? And so I was going to pursue that. But fortunately, I had talked to my neurosurgeon, and he decided he would help me intervene and get my neuro-oncologist to cooperate. He was functionally his boss, so it was not hard for him to do. We brought him in to serve the neurosurgery program. The reason he was willing to do it, as it turns out, was that he was a good friend with the chancellor of the university, who at that time was Richard Atkinson, who you may know as a very prominent cognitive psychologist, or he was until he became administrator. Now, he just recently retired as president of the University of California system. And Atkinson and I were on very good terms. I'd just recently been chairman of the psychology department, had a lot of interaction with him, and he was always very solicitous of what I was doing. We got on quite well together, and it happened that Atkinson's daughter was a neurosurgeon herself, who had trained with my neurosurgeon. And so there was a linkage there, and I did my best to make my neurosurgeon think that Atkinson and I were bosom buddies. I went a little far on that one, I think, because right after my surgery, my neurosurgeon calls up Atkinson and tells him how I'm doing. But the result of this was that I got cooperation from my neuro-oncologist, grudging cooperation, and our relationship was very strained for quite a while because of it. We basically had been told to cooperate with my unusual approach to this and let me basically do what I wanted within limits. But I still wasn't, I was still grasping at straws. I had, a couple of things where I thought were, some evidence that I could improve my chances relative to what normally happened. And it was encouraging that I could find at least some things, and it turned out, the more research I did, the more things turned up. And they turned up in part because of research through PubMed and then going to the medical school library and reading the articles and whatever. But also often by chance. And so I found out by chance of a clinical trial that had just been reported at one of the major cancer meetings. The big cancer meeting is going to come up this next week, actually. I'm waiting and hoping that we'll find something important in this. But it's a meeting called the American Society of Clinical Oncology. And there was a clinical trial on an existing drug called Accutane that you probably know is a treatment for acne. It's been in the news recently, but people are claiming it may cause teenagers to commit suicide. But anyway, it's a retinoid. What it is, it's basically a cousin to retin A, which is skin cream that a lot of people use. But retinoids have a big role in cancer treatment, it turns out. But what had happened was that people had discovered that Accutane really did benefit. Again, 30 to 40% of the patients who took it, typically by causing the cancer cells to quit growing for a while. It wasn't a cure in a sense, but it was sort of, here was tamoxifen that benefited 40% of the people. Now I have Accutane that's benefiting 40% of the people. And after a while, you start thinking in terms of, well, do these things add up? But I continued doing the research, and a couple of other things that I found that were part of the story is, one is melatonin. You all know about melatonin. It's a pineal gland hormone that's involved primarily in regulating the diurnal cycle. But it turns out that in Italy, it's widely researched as cancer treatment, and it has surprisingly potent effects. The important thing is that literally dozens, or I would say, I said there are 20 clinical trials in Italy on melatonin's effect on many kinds of cancer. And the effects are often substantial. But it's completely ignored in this country. This is in the literature, right? So these are not obscure journals. One of the bigger studies that published in the European Journal of Cancer, which is a major journal, and the effects were much bigger, actually, than most of the things that we see in most oncology journals. But one of the things I discovered is that American oncologists don't really take seriously clinical trials done in other countries. They do for Great Britain to a significant extent, and Canada. Italy doesn't make the list. So that's another case where you say, okay, here there's clearly a benefit here, and one of the trials actually involved glioblastoma brain tumors. So why not add that? Totally without toxicity. And I've recommended this to many people, and their oncologists say, oh no, you won't do that, without any good reason, as far as I can tell. Same story for another thing that's widely used. In this case, Japan. Japan cancer protocols routinely now include a mushroom extract called polysaccharide crestin, which is otherwise known as PSK. It's from a Coriolis versicolor mushroom. And it's not the only mushroom. There's some shiitake mushroom extracts and maitake diffraction and various others where there's evidence of efficacy. And again, a number of clinical trials, significant effects. The things aren't curative, but they increase 5-year survival rate from one study I recall is lung cancer from 10% to 30%. Right? I mean, a real effect. And you look at all of these and you think, well, why wouldn't you want to do these things? And people routinely are discouraged from doing these things. But in my case, I didn't care what you said, so I could get them all. I could get melatonin at the drugstore or the health food store. Interestingly, in Europe, it's a prescription drug. I don't know why that is. It's totally benign. But PSK you just have to order from some health supply company. But I could get them without any trouble. So now I had quite a collection of things. I can tell I'm not going to get through this. I start skipping over some of this. And I started taking all of them, and to my great relief, what happened was after 6 rounds of chemotherapy and having all these other things along with it, I had my first MRI 6 months after I was diagnosed. That's one view of it. It looks pretty normal. That's actually a little misleading. What happened there is the ventricles pushed some of the existing brain out to fill in the space. My more recent MRIs look a little more realistic in terms of what happened. That's sort of fluid where the tumor was. There's a little bit of a cyst left there. So here's my most recent. So you can see the dark spot. That's where the tumor was in the beginning. Anyway, I skipped over a lot of the case history because it's clear that what I wanted to say today is about the behavior analysis component of this talk, and it's clear that I need to get to that rather than. But I do want to talk about this thing before I go on. This is a different kind of MRI. This is something called FLAIR imaging. And it picks up brain damage of any kind, not just tumor. So what you're seeing there is radiation effects. Probably demyelinization, I don't know for sure, but that's what it is. So I'm fully expecting to be prematurely senile as time goes on. There are no free lunches in this. You don't come out the way you went in, I'm pretty sure. Okay. What I really wanted to do in this talk is talk about using examples from my own experience, what I learned from the point of view of thinking of things in this kind of a behavior analytic framework. And the first thing that I think anyone needs to appreciate is that you're dealing with organisms called doctors, physicians. And you need to understand what contingencies they operate under. Because you don't just go in and think, well, they're going to give me their best advice and do the best they can to keep me alive. Well, it's not that simple. Right? If you have an existing disease, if you have a disease for which existing treatments are effective, there's a whole different set of rules. What I'm talking about are diseases where existing treatments are clearly ineffective, and how do you deal with them? It's actually very hard for an academic physician to give you his best effort. And the reason is that they exist in universities. And anyone who's dealt with the Animal Subjects Committee know that you have corresponding things with the Human Subjects Committee, and in medical schools you have corresponding things with clinical trials. And they will be severely ostracized if they try and put together idiosyncratic treatment protocols. And the reason is that it gets too close to alternative medicine. And in academic centers, those are the bad guys. There's a quote I have somewhere here. I hope I can find it real quick. This is from a biologist. In science, controversy is cherished as it signals progress. In medicine, it is despised and squelched by consensus. And then it's actually a very big, clear difference between medicine and biology. Medicine is a guild, and it operates by consensus. And if you don't abide by what is the current standard of care, however arrived at, you have problems. And in medical schools, it's even more so because they claim that they're the state of the art. They're the ones who have done the clinical trials. They're the ones who evaluate the clinical trials and have reached the consensus. They're the ones who determine the consensus opinion. So for someone in medical school to make up an idiosyncratic protocol for an individual patient would actually, in principle, have to go through the clinical trial screening board of the medical school. And I'd be dead by the process before the process was actually completed. So that is a problem. You just cannot expect that to happen. And you just have to realize you have to go around the system in many, many cases. So in my case, when I wanted to take Accutane, I knew perfectly well there was no way I was going to get that out of my neuro-oncologist, so I went down to Mexico and bought it. I could get it there without a prescription. I can't anymore, actually. Mexico started requiring a prescription because it causes birth defects in pregnant women taking. It's actually causes quite severe birth defects. Anyway, the place that it is critical that you understand how things work, and it's critical that you get information on your own because you won't often be told it, is the item number C on this list, which is there are drugs out there that are useful that are not certified for the uses, for these alternative uses. Okay. So Accutane is approved for the treatment of acne. It turns out that it has some efficacy from small clinical trials showing efficacy for brain cancer, and also from various other kinds of cancers, it turns out. To appreciate the dynamics of what's going on, you have to realize it's perfectly fine for a physician to prescribe any FDA-approved drug for any purpose. There is nothing that, other than the possibility they might be sued if things go badly, which is a real concern that they have. But there's nothing in the law that says this can't be done. But remember, these are drugs that haven't passed the standard test. And standard test is a phase 3 randomized trial. These are all, the evidence for them are from phase 2 trials, which are non-randomized. There's trials where you show that the tumor regressed or didn't grow for a period of time, or there are various measures that people take. The trick is to get access to these drugs. And first, you have to know about them, which you're not told about. You have to find that out on your own. And the second is to convince people to give them to you, and if they won't do it, then how to get them on your own. Some things like melatonin, it's not in Europe, it's a required prescription, but not here, so it's not an issue. But other things like Accutane and tamoxifen is a very big issue. And I advise a lot of patients, and what I see routinely is if those patients know about these things and go in and ask the doctor, ask the oncologist, why can't I have them? Often that will be persuasive. Because the oncologist is in a very weak position. He knows perfectly well that the treatments he's prescribing don't have a snowball's chance in hell of working. But he'll prescribe them anyway. And he also knows, well, there is some minimal evidence. It's not totally persuasive, but if there's evidence, you wouldn't want to pass it up. It's a possibility. So some of them will look at it and say, yeah, you're right, it gives you a chance that you don't have otherwise. A lot of them are just totally intransigent. And then it just becomes a question of when you change doctors and try some other way of convincing them. And it's a very hard situation. But in any event, you need to understand what the dynamics are that they deal with and you need to understand what kinds of arguments that will be persuasive to them. And there is no set of rules that will work or not work in getting access to things that are not routinely used. This is it's important to realize that off-label use of drugs accounts for more than half of all treatments. So one example, for instance, is thalidomide. Thalidomide is a notorious drug that causes birth defects for pregnant women who took it. It's now been resurrected as cancer treatment and quite an effective one for some kinds of cancer. But its approval is for leprosy. Now, ask yourself, if you were a drug company, do you think you're going to make money by getting a drug to treat leprosy? Well, obviously you're not, because the places where people have leprosy don't have any money to buy it. So people knew perfectly well that this drug was going to be prescribed for other uses. And indeed, one of the forms of cancer that it works for is something called multiple myeloma. And you might remember a couple of years ago, Geraldine Ferrara, who was our one-woman vice presidential candidate, testifying before Congress how thalidomide had saved her life. She had multiple myeloma. Well, by most standards, you can't get access to thalidomide. Right? You have to persuade your doctor to let you use it if you have that cancer. It doesn't automatically happen. And how it is that drugs get to be accepted for an off-label use is a very mysterious process. It's done by consensus again, but there aren't a set of rules. But it does happen, and the patients can actually urge that process along. Anyway, so I'm going to have to move along here and run out of time for sure. This is the most important concept that I want to mention. And it's the one that's most obviously drawn from behavior analytic framework. Biological systems are multiply determined. And one of the things you learn about cancer is there are a lot of different things going on. And one of the things you also learn is that the effects are very probabilistic. You never know for any particular patient whether a given treatment will work. So you have to operate in a probabilistic framework. And one of the features of probabilistic phenomena is you do get a summation of probabilities. And this is taken directly out of science of human behavior, but especially out of verbal behavior. Right? If you've got some response that is sub-threshold in its strength, you can, by putting some more stimulus control, typically in verbal behavior, into the situation, make that response above threshold. And the very same thing happens with these treatment agents. There are things that have a little bit of effect, and you put together some other things, and you begin to get big effects. And I'm absolutely convinced from looking at many case histories of people that I have advised over the years that this is a very important component of cancer. That many of these treatment agents are synergistic in the way they react, in part because as single agents, they really are sub-threshold. And when you put them together, you do get an above-threshold effect. There's also a reason for why combinations of agents are essential, I think, and that is that the central problem of cancer treatment is the development of resistance. That a lot of people, when they go in and they have their first round of chemotherapy or whatever treatment they're having, get a big effect initially. Right? It looks like things are going well. They have another round of chemotherapy, and things are getting worse, and then the third round of chemotherapy, they find that things no longer are working. Right? The tumor starts regrowing again. It's the common story of cancer treatment. The result of that is, the reason that happens is that evolution is the enemy. The first round of chemotherapy doesn't kill everything, it leaves some things, and what it leaves are the things that are resistant. And pretty soon you have a population of resistant cells. Because of that, most cases where there are successful cancer treatments are all combination treatments. So like childhood leukemia actually can be cured pretty much these days, and it involves a combination of drugs. And it shouldn't have been difficult for people to realize this after the analogy of the treatment of AIDS. And if you look back on the history of that, it was only when people moved to the cocktail of 3 drugs that you began to get any kind of success. And there are other features of that history that are interesting. So one of the features of that history was the drug AZT. Right? When it first came out, people thought that this was really going to solve the problem. And it did have an initial effect, but fairly quickly the effect washed out. But the thing that was interesting is that when they then moved on to other treatments, it made the other treatments less likely to work as well. That you needed to have the cocktail from the beginning. You couldn't have part of it and then move to the cocktail, because what happened was that you actually did some selection that made the cocktail work less well, in addition to the individual agents working less well. And so the moral of that is that you want to put together a package of things, and there's a very easy way to see the rationale. You've got, if you have a mutation that produces resistance to one agent, is it going to produce resistance to a different agent at the same time? Mutations don't usually work that way. I mean, mutations usually are fairly specific in what they do. And so if you're hitting the cancer cell or the virus from several different directions at once, any given mutation is very much less likely to be able to adapt to all of the different directions of attack. And that, I think, is the key concept in treating cancer, and I think people will ultimately be doing that. But right now, they're not doing that as a rule. They're beginning to do it, but they're not doing it. The trick is to find a combination of things that doesn't kill you. And oncologists for a long time have been putting together different kinds of chemotherapy. In the case of childhood leukemia, it's been successful. But for most things, it actually just greatly increased toxicity to the point that it was really counterproductive. What's changed, and this is something that we need to realize, is that now there are a lot of what are called biological therapies, and Accutane and tamoxifen fall in those categories. They do not have the toxicities of a typical cancer agent, namely it kills every dividing cell in your body. These things operate in very different ways, and often in independent ways, and so it's possible to put together actually quite complex combinations of things without huge amounts of toxicity. And that's the cutting edge of cancer treatment. And when I advise people, and I probably advise 500 or 600 people at this point, so I get to see a lot of case histories. The ones who do well are the ones who put together the complex cocktails. But it's all a result, really, of the fact that evolution is your enemy. And you have to figure out how to go about dealing with it. I'm running out of time here. We started at 1:30, so I should be stopping at 2:20. Okay, so I'm at 2:20 now. So I didn't get to some of the things I wanted to say. The variation idea is don't be satisfied with the sources of information that the medical establishment gets you. The one thing I did that was out of the ordinary was I found information everywhere. And in many cases, in unexpected places, I would call up people asking about treatments, and they start telling me about something else they were interested in, and often that was the most useful information I'd had for a while. So the more varied your search behavior, the more likely something will result from it. Once you select through it, that will be very useful to you. That's your behavior that matters in that case. The other is don't dismiss animal models. Oncologists these days are fairly dismissive of them because there have been so many cases where they just didn't pan out. The adage is it's easy to cure cancer in the rat, but it's not so easy to bring it into the clinic. Well, they ignore a lot of things that are clearly beneficial, that are easy to bring into the clinic. Often nutritional kinds of things like the mushroom extract that I mentioned, for instance. There are many kinds of things like fish oil. My advice to everyone in this room is start taking fish oil supplements. It does many, many things, but among the things it does is it has a very powerful effect against cancer. There was a study done in Greece that showed that people who took fish oil, advanced cancer patients who took fish oil, lived twice as long as those who didn't take it. Didn't cure them, or didn't cure that many of them, but it's better to live twice as long than not. I mean, but there are many things of that nature where people started with animal models, brought them into the clinic, and in fact they do work. So you should not dismiss animal models, particularly for those cases where the models are involving things that are very benign and easy to get. It's just crazy to ignore them. What else do I have here? This is what I actually wanted to spend a lot of time. It's a very difficult thing to do shortly. So the real problem with medical research is that they have fallen in love with null hypothesis testing as their mode of analysis, and it's an utter disaster. Right? That is not the way to find out whether you get a clinical benefit from a new treatment agent. I mean, it's just not. And I could spend a whole hour developing that concept, but I don't really have time, so I'm going to stop. Thank you very much. Well, I chose not to be in any clinical trials. I didn't talk. What part of what I left out is the nature of the clinical trial structure, and the history of clinical trials with brain cancer is they've been a total failure. I mean, I don't know of a single one that. When you start moving into more advanced clinical trials, they just haven't worked out for one reason or another. But they will not let you do drug cocktails in clinical trials. And it was very clear from the beginning that was going to be an essential component of what was needed. And that's still the problem. The AIDS cocktail has never been assessed in a bona fide phase 3 trial. The reason it got it out there was because of politics. I mean, there's a lesson there. And I played some role in trying to get the government to quit worrying about phase 3 trials as a way of certifying treatments. I mean, it really makes no sense given the widespread off-label use of drugs. They don't have phase 3 trials in almost every case, and yet it's perfectly okay to do that once the consensus has been reached that these are good things. And the question is, how much of a consensus do you need? Yes?
How do those doctors treat you now? The oncologists who give you a difficult time. How do they, have you talked with them and have you changed their mind about it?
Well, I was invited to a conference a couple years ago that was convened very hastily for a billionaire who had a glioblastoma diagnosis. He was convening all the experts, and I was the only civilian there. And I gave a talk. I was the token survivor, is why I was there. I gave a talk at dinner, and I got many of the neuro-oncologists angry at me. On the other hand, the neurosurgeons that were there thought it was perfectly fine. There's a very big difference between the mindset of surgeons who think, yeah, go for it. If it's not working, change what you're doing. They don't spend all their time diddling around thinking about how do you change this clinical trial protocol. Go ahead and do it, and see how it works. Whereas the neuro-oncologists are just plodding along and want to add one thing at a time, and they were not happy with the idea that you're just going to put together a bunch of things, even though the things you're putting together are relatively benign. But what I've seen over the years, and I do take some credit for this, is I can tell you 4 or 5 neuro-oncologists in the country who are now using drug cocktails. And I even had one of them send me an email saying what was I recommending. So some of them come around, but it's not that many that come around. Bill?
You thought fish oil was a good thing for people to take. Do you have any other recommendations of things that people should take?
Melatonin. I still take melatonin every night.
How much?
I take 10 milligrams every night. Puts you right to sleep. The mushroom extracts are also just a tremendous amount of evidence that they work.
Well, maybe not so much for people with cancer, but
things that cure cancer usually prevent So I let that stop. Yeah.
Did you keep a journal as you were going through this?
I didn't think I was going to live long enough.
That's what I wondered when I read the book. I wondered if you wrote it retrospectively. It didn't sound like, as I was reading it, that you had actually kept a journal.
I did not keep a journal, but I had my wife to correct me if I made mistakes. But I must say, you have a very vivid memory of the critical episodes and the things you will not forget. Seeing that first MRI, I can see it on right now. Yeah.
I'm sorry, what else do you still take now?
Well, it's a very long list. I'll tell you afterwards. I actually have to think about it. Maybe I've already taken it today. I was carrying around a thing of capsules, whatever that I there are a whole bunch of things. I spent a lot of money on supplements. I don't know. I would advise anybody normally to do it. I've been known to have bills from my supplement supplier of $1,000 routinely. Yeah.
Have you advised anybody with the same diagnosis you had who's had similar results to your own?
Well, none that are 9 years out. I mean, I've had several people who now have clear MRIs. The problem is when you advise people, they'll do part of what you say, and then they meet resistance from their oncologists and they sort of give in half the time. The ones who are aggressive, the one that I've been advising someone in Australia, and he went from having a lot of tumors and clean MRIs, and he's had them now for over 2 years. So you can't really make a real science out of looking at individual cases, but given that the base rate is 0.5%, any individual case actually does carry some information. People need to realize that.
Given what you know now, you don't know at the time what you think.
Well, I didn't really have a choice because I was beginning to show what's called a mass effect. My tumor had gotten so big that it was pushing my brain off to the side. So you get what's known as a midline shift, and that's the beginning of the way that many people die of brain tumors, which is sort of like a glacier effect. At some point, pressure gets so much that it tears off part of your brain and you die of internal bleeding. So I was beginning, my neurosurgeon actually told me if I had not had the surgery when I did, I would have been dead in 2 weeks. So, yes, I would have had the surgery. Yes?
Was fixed treatment the normal course of chemotherapy for this kind of?
It depends on the chemotherapy. A lot has happened in the last 9 years. There's actually a new chemotherapy drug that's most commonly used now that wasn't available then, and people have been known to take that for 2 years. I mean, usually not, but that's not heard of. It just depends entirely on the chemotherapy protocol.
So often they want to give you chemotherapy and they will not stop. One more treatment will kill you with the chemotherapy.
Well, yeah, I mean, the biggest problem with chemotherapy is that it drives your blood cell counts down, and the one they worry about the most is your white cell count. And indeed, at one point, I had a near zero white blood cell count. I was lucky that something bad didn't happen. And I was anemic for a long time after I quit having chemotherapy. I was probably anemic for a good 3 or 4 years afterwards. There are a lot of weird things that go on with this kind of thing, which is most clinical trials involve people who have failed standard treatment. Well, it turns out that's a very poor way of finding out whether a treatment will work, because these are the worst candidates, right? I mean, why do you load the deck against finding a treatment that works? And it's just routine, and that's really a function of the FDA. I mean, the other moral, that general moral I leave you with that I didn't talk about is the FDA is the enemy. They've done so many terrible things, getting in the way of access to treatments. And the AIDS treatment, the perfect example, they fought it tooth and nail, and it would not be available had it not been politically forced out of them through Congress. But they do lots of things. I mean, and And one of them is, in fact, restricting the initial trials to people who are on death's door in many cases. Yeah, I guess we're. Yeah. Okay. All right.